Broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. Good morning, and thank you for joining Fight Colorectal Cancer's webinar today on physical therapy for CRC patients and survivors. Sorry we're running a couple minutes late. We had some technical difficulties this morning. But regardless, we're really excited to have Alaina Newell joining us today. My name's Sharon. I'm part of the Fight CRC team, and I want to thank Michael Sola, Reese Garcia, Danielle, Burgess, the whole communications team for all their support in carrying out the webinar this morning. So just a few things before we get started. Again, our speaker today is Alaina Newell. She is a physical therapist working out of the Denver area at Oncology Rehab. We're super excited to have her here today. You're able to ask questions during the webinar on the right side of your screen. You'll be able to type your questions there, and we will host a Q&A at the end of the webinar presentation. You also can follow the webinar. You can rewatch it if you'd like after the webinar live presentation by going to fightcrc.org/webinar. And follow along on Twitter if you have a Twitter account using the hashtag CRCwebinar. And finally, post-webinar, you'll be receiving an email with links to the material and a survey. So if you fill out that survey, we will send you a Fight CRC bracelet as a thank you. Here's some technical support. We're using GoToWebinar to host this webinar session today. Again, on the right-hand side, you'll see an arrow that says questions next to it. Feel free to type in your questions there. And of course, Fight CRC offers a variety of resources, including our Tabooty podcast, mini magazines, and Your Guide in the Fight. So visit fightcrc.org to learn more about our latest resources. And just a quick disclaimer, the information and services provided by Fight CRC are for general information purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnosis, or treatment. If you are ill or suspect that you are ill, please see a doctor immediately. And in an emergency, call 911 or go to the nearest emergency room. Fight CRC never recommends or endorses any specific physicians, products, or treatments for any condition. And finally, here's our wonderful speaker for today, Alaina. She has received her doctorate of physical therapy from the University of Pittsburgh. She's one of the few board-certified women's health clinical specialists in the Denver metro area. And she's worked with a wide variety of different cancer diagnoses from melanoma, pancreatic cancer, bladder, ovarian, colorectal, and more, in addition to women's health needs. So we're super excited to have her here today. And Alaina, I'm going to hand it over to you.
Hi, thank you again for joining us today. She just gave us a little bit of background on myself, but the next slide, if we move to, will tell you a little bit about what we're going to go through today. So first, I'm going to give a little bit more introduction in terms of how our clinic got started. That's something people often ask us about. And then we'll go through the who, what, when, where, and why of physical therapy for CRC patients. And then I'll talk about our outpatient approach and the different aspects we treat. And then our top 5 impairments and things that physical therapy can help address and types of treatments we utilize for those. And then at the very end, have a couple of patient resource slides. She just gave me a great background. So what I'll do is I'll kind of go a little bit onto what oncology rehab is. We are an outpatient-based clinic in the Denver area. We currently have 1 main location and 2 satellite locations in which we're building. And we treat all different types of oncology diagnoses. A team of us is starting to build our program that specifically focuses on different digestive cancers, and obviously with our colorectal falling into that realm. We do have a comprehensive team of physical therapists, occupational therapists, and speech and language therapists who can also sometimes touch on other aspects that may not be mentioned today, but maybe are side effects you're curious about. For instance, anyone who might be handling some chemotherapy, brain fog, is definitely something one of our speech and language therapists focuses strongly on. I won't go into the more details than she just gave. I think the only thing I'll highlight at the end there is at the end talking about oncology rehab specialists through our PORI certification. That is a certification that we started at Oncology Rehab that works on a physiological approach in terms of approaching patients with cancer and their rehabilitation needs. So if we move on to what is our next, or sorry, I apologize, who is our next aspect is who are we? We're licensed physical therapists, so we're licensed from a state licensure, but it's a national board and accreditation. And the baseline education right now is a doctorate of physical therapy. Over time, that has evolved. And we've also evolved to have many different board specialized certifications. She mentioned that I'm a Women's Health Board certification. That's the WCS. We also have physical therapists who are neurological specialists, geriatric specialists, orthopedic specialists, and several others. Currently, the section of oncology in the American Physical Therapy Association, we're in the middle of developing an oncology-specific specialized exam, which should be released in 2019. So in the future, that would be a designation to look for in terms of a patient, or in terms of a therapist, is looking for that designation, that oncology designation. Other therapists also have additional training depending on their experience. One includes a CLT LANA, and that is a certified lymphedema therapist. Oftentimes, colorectal patients don't have as much swelling difficulties as other patients with oncology diagnosis, but if you do, that would be a person to approach and someone who could help with the lymphedema aspect, even if they don't specialize in oncology alone. That next designation is for biofeedback certified trainer in pelvic floor dysfunctions. We'll talk about later as a treatment option for fecal incontinence is biofeedback training. And so that person may have a more expertise with that tool. The next one, as I mentioned, is PORI. It's our Physiological Oncology Rehabilitation Institute certification for oncology specialists. The next one is a functional dry needling, or dry needling in general, is a modality that physical therapists have started to use more frequently, including in the oncology population. One thing I think to always promote is that physical therapists help teach patients how to prevent and manage their condition and aiding in their long-term health and wellness. And we do that in a very individualized plan. So I can't tell you exactly what the physical therapist will do when you meet them, but at least hopefully after today, we'll give you some ideas of topics to touch base with them on needs you may be having. Now let's switch over to where physical therapists work. I apologize, my brain keeps flipping one ahead. So first we'll talk about when. When do we see patients? We see patients prior to their treatments, during active treatment, and following. And that following may be years later down the road. We like to start our plans, if we're able to, before the start of surgery. That gives us an idea of the patient's impairments going into this diagnosis and treatments. That's not always an option, and we understand that. And so we definitely are happy to start therapy whenever we're able to. One thing that physical therapists who focus on oncology have a little bit different is we have a better medical understanding of the treatments you're undergoing, and we stay up to date with the different type of treatments available from a surgical standpoint, a chemotherapy standpoint, and a radiation standpoint. As you all have experienced as you're in the field, oncology is rapidly changing. So something a friend may tell you they had done 5 years ago may not be applied to you nowadays. And that's one thing we strive ourselves to staying up to date on that understanding to make sure what we're going to work with you is appropriate given where you currently are. After treatments have subsided and you've gone through your active treatment, some people still feel like they have side effects that are lingering. And that's where physical therapy, I think, is one of our strong suits of coming in and helping you deal with the long-term management or relief of some of those conditions. Some conditions we will be more better in terms of helping you manage than actually treating, but we like to provide you with the tools and how to be able to do that and then integrate them into your everyday life. Just some examples of those symptoms might be chemotherapy-induced peripheral neuropathy, that numbness and tingling you may feel in your hands or feet, weakness, whether it's a specific muscle or just an overall body weakness, fatigue, whether that be a little bit base cognitive fatigue and or physical fatigue, bowel and bladder dysfunctions, and that can range as a small, mild incontinence that you only feel every once in a while to a severe impact event of your everyday life. We work with scar conditions and soft tissue through manual therapy. We help reduce pain and then help you and give you the tools how to manage lymphedema and get you the resources appropriate for that. Where is physical therapist? Where do we work in this whole scheme of things? We are present in all aspects of the medical realm. Anywhere from acute care hospitals, maybe seeing you the day of surgery or the day after surgery and working on that basic mobility, to anywhere in the transitional care units, maybe you need an inpatient rehabilitation stay or a skilled nursing facility for some rehabilitation, all the way moving into our outpatient realm. Maybe that also includes assisted living, or if you became more homebound, we also provide home care services. The one aspect where physical therapy doesn't enter is into hospice. Once our patients have transitioned to hospice, we do hold our care at that stage and allow the hospice team to take over. Depending on which setting you're in at the moment, will be a different focus of physical therapy. In acute care, our main focus is to help you get and restore your basic mobility needs, including from moving from the bed to your bedside chair or into the bathroom, and be able to transition you back to home or into a rehab facility. So be able to walk a distance of a hall, either by yourself with assistance or an assisted device. Once you've moved into those next levels of rehabilitation from an inpatient standpoint or at a skilled nursing facility, it's really starting to build up your strength and starting your posture, your endurance to help you fully transition back to your home unit. Once you've returned home, outpatient physical therapy has a much greater focus on dealing with some of the more detailed impairments you may have and really allowing you to improve those to improve your everyday daily activities, help you maybe return to work, or to increase your exercise and recreation at that time. One thing to note is, sorry, I apologize. One thing to note, they said we're not included in hospice care, but we do see patients during their palliative care time. So it's important to recognize that whole continuum, and that if you choose at some point you need palliative care, physical therapy can still be part of your team at the time. Why physical therapy versus a lot of other options? We recognize patients have many options between physical therapy, maybe occupational therapy, acupuncture, massage, Reiki therapy. There's a whole slew of different practitioners out there who assist in improving patients. Where we pride ourselves is really improving your quality of life and really what that means to you. Some studies I was looking at show, the increased survival rate for CRC cancers is pretty high. And when they've looked at surveys of quality of life in this population, they say it's good. My question though is good enough? I really would love to say patients have great quality of life or an excellent quality of life, if we can maintain that. And so again, some of those aspects are to reduce fatigue, prevent bone and muscle loss, and improve quality of life are really why we come into play more so than some of the other practitioners around. Physical therapists are able to start exercise in a very low level and safe manner and to help with injury prevention down the road. We also are one of the strongest aspects in providing non-pharmaceutical interventions to reduce your pain, bowel and bladder dysfunctions, reduce shortness of breath, fatigue, and other impairments you may have. So if this sounds like something that is appealing to you, you might be wondering, how am I going to get there? The first thing to do is to talk with your medical team. Talk with your oncologist, maybe your surgeon or your radiation oncologist, and say, I heard something about physical therapy and was wondering if you could help me get the resources from my local area and get a referral. If they're unable to do that, I do have a couple of the main websites on here who are able to help with those resources as well. The American Physical Therapy Association has Moving Forward, and there's a place there to find a therapist near you. If you would like to try to find a therapist that's a little more specific in their skills, the oncology section also has that aspect, as well as a section of women's health. I particularly include the women's section of women's health for anyone who is having any bladder or bowel dysfunctions, and we'll talk about that a little bit farther into presentation. So like I mentioned, I mostly work in an outpatient setting, and so I wanted to give you an idea of how we navigate patients based on their diagnoses. So when we have a new client come in, we first look at what types of treatments they've already had at this point and or what are planned for the future. So whether they've had chemotherapy, whether they've had immunotherapy, surgery, or radiation, that helps us start to navigate of what type of treatments we anticipate they'll need or what type of assessments we want to make sure they have concluded in order to prevent or reduce any symptoms they already have. So someone who undergoes chemotherapy will have 2 assessments at our clinic. They'll have a neuropathy balance assessment, and they'll also have a cardiovascular assessment. If we can help reduce falls in every age and population, we know we can reduce the amount of injuries and risks and medical decline. And so by having that baseline balanced neuropathy assessment helps us understand what the patient's fall risk is, but it also helps start to develop tools and resources for them in their everyday life and how to manage these symptoms while they're in active treatment or if they're long-term. Performing a cardiovascular assessment gives us an idea of how a patient's body is tolerating exercise. This helps us develop a exercise prescription at this time that is tailored to them. Oftentimes we look at exercise and people tell you to monitor your perceived exertion or to monitor your heart rate, or just say, hey, go out for 30 minutes. In the oncology population, we found that there's 4 main phases if we allow patients to follow. They're going to reduce their fatigue. And those 4 phases are based on what their resting heart rate is and what their exercise tolerance is. And then we are able to calculate an appropriate heart rate range in order for them to exercise in. There's strong research coming out of the University of Northern Colorado showing that if patients are able to follow these zones, they reduce their fatigue, but they also increase their cardiovascular stamina during chemotherapy, which is commonly known to actually have the opposite side effects. So we'd like to get patients that understanding is early on in their chemotherapy process if they can, but if not, we do it at any point along the road as well. That next section of immunotherapy has similar drivers in the sense of looking at their cardiovascular assessment and can we get them on a strong exercise plan based on how their body is handling that treatment. If someone has surgery, surgeries can vary drastically in this population, so I kept these aspects generalized. Oftentimes impairments we see is patients with soft tissue, whether that be scarring in their abdomen or if they have an ostomy, learning how to care for that site and utilizing their muscles and tissue around. We also develop exercise programs that have a focus on strength, flexibility, endurance, and balance. We work on Balam bladder management based on the treatment, as well as their sexual health. And last but not least is ensuring that they have good posture and gait moving forward. Different surgeries can impact people different ways, and we're not always sure until you come out of it. And so we like to kind of get these assessments and go from there. Last treatment that patients often can undergo is radiation treatment. Some of these are very similar to our surgical patients in terms of the impairments they have, but for a different cause. And understanding what the tissue that has been radiated, how it will act and move with them forward in their lives. If we gather all of those aspects together, again, our biggest important aspect is to improve a patient's quality of life through their function and exercise. When we look at, when I put together our top 5 impairments we see in our clinic for CRC patients, my top 5 I would say are CIPN, chemotherapy-induced peripheral neuropathy, cancer-related fatigue, CRF, muscle weakness is imbalance and leads to postural dysfunctions, scar tissue as well as soft tissue management, and then bowel and bladder dysfunctions. We'll go through each one of those at this time. So our first one is the functional impact of CIPN. CIPN is damage to your peripheral nerves, so the nerves that move away from the brain or their spinal cord that are from chemotherapy agents that are known to be neurotoxic. Each chemotherapy agent can affect nerves in a different aspect, and that's what this diagram is showing here, the different drugs in terms of where they intervene in the nervous system. Symptoms from CIPN can vary from patient to patient and have a small impact to a very large impact. Some patients experience pain, burning, tingling, numbness. That's often what we ask for if people are having that in their hands or their feet or their toes. If they're starting to have balance difficulties, whether it's from that sensation in their feet or if their vestibular system's been impacted. Fine motor problems, people will notice difficulties with handwriting or putting buttons, tying shoelaces. Sometimes people experience a hypersensitivity, so a small touch feels much drastic to them, or they feel like they're walking on needles or on sandpaper. Sometimes this can actually lead to some of our bowel and bladder dysfunctions, and people also can be noted with decrease of reflex. In order to treat a patient with CIPN, we'd first do that full balance assessment, and then following the balance assessment, we do a fine motor assessment, how their hands are functioning to start to build them some compensation pathways. Most of our patients, if I know they're going through chemotherapy, I will tell them keep moving. While you're having the infusions go on, wiggle your toes, roll your ankles, move your hand up and down. Keep those extremities moving to allow that blood flow to the area in hopes to reduce the amount of impact that neurotoxins have on the nervous system. So if in doubt, while you're sitting there for your infusions, move your toes, move your fingers as much as you are able to. Our next one, looking at cancer-related fatigue, is some of the strongest research when it comes to rehabilitation and oncology patients. What they have found is that the most beneficial aspect to reduce fatigue is with exercise. I talked a little bit of that progressive cardiovascular test we do at our clinic, but in general, what you want to do is monitor your heart rate and have it in a comfortable zone. You want to be able to have a full conversation while you're exercising early on in your cancer treatment. Your goals should be shooting for 150 minutes of exercise a week, and we balance that between 90 minutes of cardiovascular endurance and 60 minutes of balanced strength and flexibility. That may seem a lot at first, especially if you're in the middle of treatments, but keep in mind that doesn't have to be all at one time. We often start patients off with maybe 5-minute bouts of walking, maybe 10 if they're able to tolerate that, and doing a couple sessions throughout the day. So that could mean you could go for a 10-minute walk after breakfast, a 10-minute walk after lunch, and maybe a 10-minute walk before dinner. And that would give you 30 minutes of exercise in one day alone. So if we break down that 150 minutes, that gives you 5 days of 30 minutes of exercise. You can also stack that and tailor it as you need to based on when your chemotherapy treatments are. So if you know day 2 and 3 are more difficult for you, maybe you only shoot for 10 minutes of exercise that day. But then as your week progresses and you know you feel a little bit better, you can increase your activity as well. When we look at muscle weakness from chemotherapy, most likely, but also surgery, is oftentimes patients start to come with these really impaired postures. So oftentimes I have people look like the guy in the exact middle. His head's starting to come forward, his shoulders are rounding, his upper back's rounded, his stomach is kind of tightened down. And where those really start to have play on individuals is you're more forward you are, it's harder to breathe. You compress your abdomen and your digestion will slow down. The more forward our weight is, it's harder for us to walk and keep our balance. If you stay in postures for a long time, it can lead to poor sleep because you're not able to get into comfortable positions. And then it also increases our joint pains and muscle weaknesses. Joint and muscle pains. One thing when we work on learning to increase strength in individuals initially is really just getting back to an upright posture. So that man that's on the very far right-hand side is ideal, but we know not everybody will achieve that. Our goal is to see if we can get you some points of stability within your shoulder blades, your abdominals, and your hip muscles to be able to keep your body upright and allow it to physiologically function the best it's able to. I mentioned a little bit that we do a fair amount with patients in their scar tissue and their soft tissue. I have a picture of a gentleman here who just has a couple of examples of different surgical scars you may be experiencing. Each of these scars, in my eyes, leads to potential dysfunctions. Sometimes they do and sometimes they don't at all. But my whole goal at the end is to have the tissue to be able to move and move freely where you don't notice or feel your scar. If we're able to open up those restrictions, it can help reduce some side effects that you may have secondarily. So sometimes with a lot of scar tissue in your abdomen or soft tissue restrictions, people start to have bowel obstructions they have over the time. They can also be very painful. We talked about that forward posturing. If your abdominal scars are really tight, it's hard to stretch and open those up. It's also hard to get you to use your abdominal muscles in an effective manner to give your trunk support. Anytime we have extra scarring or tightness in there, it doesn't allow for your urinary tract and your colon to work as effectively as they typically do. And sometimes patients end up having side effects like urinary and fecal urgency, frequency, or incontinence. The last piece along this standpoint is really to start to support a positive body image. This is a really difficult time in your lives. And if we can make you feel a little bit more in your own skin and who you are and not always reminded of your scar, that sometimes that alone can also help in your recovery and support. The last section that we'll actually spend a little bit more time on is the bowel and bladder dysfunctions. I know oftentimes patients struggle with these aspects, and it can be one little piece or it can be all inclusive. So I just want to review the different types of dysfunctions we see. We see urgency, that feeling of, oh gosh, I need to go right now, or as soon as you get in your driveway, you need to run to the bathroom. Frequency, you notice you're going more frequent than every 2 hours. In a normal daytime, you should be going to the bathroom one time every 2 to 4 hours. During the evening and while you're sleeping, it should be able to get up no times during the night or maybe one depending on your age. Incontinence can be very mild from I have a little drop of leakage when I cough, laugh, and sneeze to feeling that your whole bladder empties at times. It may also mean the opposite in the sense that it's really difficult to start your stream or to start to get a bowel movement. And then if you do able to get it started, you're not able to actually finish emptying. So you can tell there's more there. Maybe you get off the toilet and you have to come back 5 minutes later. If it's painful for either of these, to either start during bowel and bladder movements or afterwards. And then hesitancy, I mentioned a little bit there that I feel like I need to go, but I just can't start it. When we look at treatment options, there's a variety of different options that we utilize. Some is manual therapy to help cue you in and feel what may be going on. We also look to increase different exercises to be able to help you re-understand how to use your pelvic floor muscles with your abdominal muscles, as well as your diaphragm and breathing. I'm going to come back to that biofeedback training in one moment. Dietary and lifestyle changes, those can include maybe we need to try to increase the amount of fiber you have in your diet, or we need to look towards when you have different beverages or foods throughout your day. We talked a bit on postural awareness and just understanding the impact of the more forward flexed your posture is, the worse your symptoms may get at times. Sometimes people's mechanics in terms of how they use toilets is a little bit in dysfunction. So we really try to get people back towards a normal squattive type of position, but using the toilet. So using assistive devices to get maybe under your feet, and then the whole breathing mechanics while you're at that time. Let's head on back to talking about biofeedback training. This is an often question because it's been used for an extensive amount of time when it comes to fecal incontinence. We look at the literature, it dates back to about 30 years. Biofeedback training is a tool device we use in physical therapy that we utilize an electrode, and those can either be placed externally around the anus or they can be with an internal sensor. And then that sensor is hooked up to a computer. On the computer, it's going to provide you with a screen and shows you when you contract and tighten your pelvic floor muscles, how large of a contraction you're able to get. And then when you fully relax your muscles, how far can they relax down? We can utilize that mechanism in our exercise time to find out, are you getting a strong, effective contraction every time you try to do it? Or maybe that first time is a great contraction and trying 3, 4, and 5 are not quite as strong. So it gives you a visual input in terms of what your muscles are doing. This really aids in our patients who have some weaknesses from over time or with having surgery and have had changes in their rectum and understanding how to reutilize these muscles and come back into contact with them. Biofeedback primarily has been used mostly in clinical settings, but there are a couple of devices now that are in the home market as well. I usually advise patients to work with a therapist in terms of setting up a program to utilize at home, and then they can use the biofeedback machine at home, get some training, and then come and check back in with a therapist in terms of how your symptoms have changed, or maybe we need to modify which program you're using at that time. Okay. So I think at that point, the next page, all I do is have a couple of resources on there. I was going to see if we have any questions at this time, and I'd be happy to answer.
Hi, Alaina. Thank you so much for taking the time to run through this presentation with us. Can you hear me okay?
I can.
Okay, great. So we did have a couple questions come through, and we can go ahead and address those now. So for patients who have low anterior resection syndrome or LARS, how might PT be used for these patients that are experiencing a collection of symptoms?
So yes, that is definitely something commonly we see. I think it depends on what their symptoms are. So it has to be, again, we usually as physical therapists like to sit down in that first visit. It usually is a lot of talking to find out what your different symptoms are and then build a plan based on them. Oftentimes with those is the amount of abdominal support and structure they have is usually not very effective. And so it's really, can we get them to start to utilize their abdominals again from a posture standpoint, but then also how to soft tissue, loosen, and allow for a better evacuation.
Great, thank you. Let's see. So this person noted that they're struggling with painful vaginal scar tissue following the removal of the rectum. Is there anything that she can do to address this, or is this something that physical therapy doesn't address?
That is a huge aspect, and thank you for bringing that up. I had mentioned a little bit about that section on women's health. So physical therapists who say they work in women's health also do treat men. And one big thing we utilize is either vaginal or rectal exams, but assessing the tissue in that area. So different vaginal pains can either be from dry tissue, it can be from radiation tissue that has some fibrosis, so tightening of that tissue. And we as physical therapists work hugely in that room. So what I would advise is to make sure you're working with a women's health physical therapist, and they will understand how to address those impairments better. They can work on either in the clinic, but also getting on a home program in terms of how to massage and start to stretch the tissue, whether that's done manually or potentially using dilators and different lotions and lubrications that may be needed to help move those structures.
Interesting. Okay, so that is something that a patient could talk to their doctor.
Absolutely.
And see a physical therapist. Great.
Yes, absolutely. And but definitely finding a women's health physical therapist will be the key.
So that leads perfectly into a follow-up question. How does a patient find a physical therapist if they're not given a referral? And then to add on specifically, if they're looking for someone trained in women's health specifically, is there somewhere where they can go online to find someone?
So a couple slides back, there was a page about how, and that page has 3 different resources on it. It has 3 links. The first one is the American Physical Therapy Association's Moving Forward link, and they have a Find a PT, so find someone near you. Also, then there's a section of women, oncology section and a section of women's health. That section, if you put in your address or you put in your zip code, it will pull the therapists that are nearby you. The women's health specifically also has each therapist mark down what type of conditions they treat. So you could see if they have, if they say anything for vaginal pain, that would be a perfect spot to look for.
Great. Along kind of the same lines, we have a question about when do you know when is physical therapy not right? Is there any time when a colorectal cancer patient might be looking for physical therapy and be turned away from the treatment?
I would say oftentimes we don't turn patients away, but sometimes we'll direct you back to your oncologist based on your symptoms. One thing with our training now is we're doctors of physical therapy, and when our education shifted, a lot of it was to understand when a patient's appropriate and when they're not. Rarely do we not see patients in their continuum. Sometimes if they are having really low blood counts and their oncologist doesn't want them out in the public, sometimes we won't see them in those standpoints. The other most common time is if a patient has an active infection. So for someone who has an active infection not treated on antibiotics, we will direct you back to your oncologist that day, or if necessary, go to urgent care to get those treatments. Sometimes we also like to provide, increase the other practitioners you may be seeing. And so we can definitely help direct you towards maybe you need a massage therapist, maybe you would benefit from other services. And so we will direct you in those fashions. One thing I didn't mention is a lot of people think of physical therapy after they've, had a knee surgery or they injured their back. And how we work in our continuum doesn't mean you're going to come into therapy twice a week or 3 times a week for 4 weeks. We often work with much longer periods of time with patients. And so we see you maybe once a week or even up to maybe just once a month. But we often say then, like your oncologist, you're almost a patient for life. We're kind of that resource there for you that if you're having any, pain or you're having dysfunctions that you feel might be in the therapy realm, is come back and check in with us because we'll know your history, we'll know what you've been through, and that helps give us a better idea of, hey, is this a pain we need to refer back and see the oncologist for? Or maybe you were out working in the garden and you injured your back and pulled your back a little bit, and that's something we can help address. So rarely the 2 times of an active infection, or if your blood counts are too low, they're not wanting you interacting with much public, sometimes we'll hold patients at that time.
Thank you. We just have a couple more questions come through. One is really related to what you were just talking about. So when a new patient comes to physical therapy to address some of these CRC side effects and concerns, what is the typical schedule like? Is it once or twice a week, or is it less often, more often, or does it vary?
It varies drastically. I have one gentleman right now, I'm seeing him twice a week because he's having a lot of pain, but also a lot of walking impairments. In the same day, I had another patient that we check in every 6 weeks. So she is at this point through the majority of her treatments, but for her condition, she's going to be on chemotherapy for a prolonged time through probably the extent of her life. And so her and I check in about every 6 weeks, make sure her exercise program is going okay, make sure she's not having any side effects from her chemotherapy, and then judging it based on there. So it can definitely be a continuum. Sometimes we go in different spurts. So maybe we see you once a week for 6 weeks, maybe 8 weeks, and then we don't see each other for 3 or 4 months, and then maybe you come back again. So our treatment courses are pretty varied based on the individual needs, but also understanding where you may be in your life. I understand and we appreciate that at this time you have a lot of different people you're needing to see, especially if you're having chemotherapy and radiation and surgery, and to add one more appointment in may be too much. And so letting your therapist know what your needs are, but also what you're able to do at that time is helpful for us to figure out how much can we give you at home to do. And maybe we check in by the phone or email and how much we need to do actually within the clinic.
Great, thank you. And the last question I have for now, and don't forget people that are on the line listening live, you can type in your question on the right-hand side of your screen. We do have a couple more minutes. But my last question for now is, in your personal experience, what has been the success rate of using biofeedback to help patients with incontinence?
Mm-hmm. It really depends to me on when they're having incontinence, and B, what may be leading to their incontinence. So I definitely take time to figure out Is it that they're having incontinence based on the type of stool characteristics they're having? Is it a functional incontinence, or is it a structural change? So depending, if it's someone who has, let's give an example, someone who has a lot of runny stool, and they find that the stool is just so runny that they feel like they're running to the bathroom, and that process they're having leakage. Oftentimes those patients definitely can benefit from some biofeedback to get some strength, but more importantly is saying, can we get you to change the type of stool you have? Can we find something that will help aid you in bulking up your stool? A stool that's a little bit thicker is a little easier to control with your pelvic floor muscles. If someone has a structural change, depending on the location of their tumor, depending how much rectum they had to remove or where specifically it was, is they may be lacking some of the sensory and internal body signaling that tells you when stool has moved into your rectum. There's 3 stop gaps, so if you're missing that first or second or third stop gap of understanding stool is entered into your rectum, it's much harder to control it if it's right at the end and right at your pelvic floor muscles and moving to your external sphincter to exit. So what we try to do in those situations is sometimes biofeedback is helpful, but more effectively, it may be helpful to use a rectal balloon to understand what the pressure feels like when it's in your rectum, and then use your pelvic floor muscles. So structural changes sometimes aren't quite as helpful if they do have good strength. If it's a functional incontinence or a functional abnormality, and what I mean by that is I can control it 75–90% of the time, but every once in a while I have these incidences of leakage. Usually those ones are telling me that it may be more of either the specific situation. Did they wait too long to use the bathroom? Or did they eat something different? Or was their body much more fatigued in that forward flex posture? So their pelvic floor muscles were at a disadvantage from the downward pressure. Those ones, we can sometimes put them in the functional positions that have impacted them and try biofeedback then. Maybe that their pelvic floor muscles are strong and testing well when they're sitting, but maybe it's not when they're lifting down to pick up their kids. And when they're holding their kids and then they have the urgency to go to the bathroom, maybe we need to combine those 2 activities together to build their strength. And so biofeedback, I like to emphasize, as a tool to help you understand what your pelvic floor muscles are doing, and potentially also build you a strengthening program to see the consistency of your contractions. So to me, overall, it's a decent success rate, but I also don't use it for me personally as my primary tool, because I don't think everybody's dysfunctions are pure weaknesses.
Interesting. So it sounds like if you're going in to see a physical therapist for incontinence, then really paying attention to what's going on in your body and can really help determine the therapy and the treatment that you'll receive.
Absolutely.
Awesome. Well, Thank you so much. We don't have any other questions that have come through. So I guess we can go ahead and wrap up. Thank you to all of the listeners who were able to join us live today. And again, thank you to the Fight CRC team. Oh, hold on. We have one more question coming in. Okay, this is a good one to end on. So people are now hearing the term prehab or prehabilitation. So before going into surgery or before going into radiation, are there things that you can do in physical therapy that can help, prevent some of these side effects like neuropathy, incontinence, and others?
Our prehab program at our clinic is probably one of our quickest growing programs right now. And I definitely find the research is really getting strong in supporting how much prehab can do for individuals. It got started back with patients with cardiac problems, and if we could give them some prehab, how they would do coming out of cardiac surgeries. And so we started to apply that model into the oncology population. And honestly, to me, I think this is where therapy needs to grow more, and it is. There's the studies that have came out, there's only a couple of them so far, have really strong results that showing the stronger the person is going into their treatments, the stronger they'll come out. And not only in a little bit, but in a pretty impactful way. So one of the biggest things people find as they go through their treatments is I wish I had a little more strength, a little more stamina as they're going through it. Well, maybe we can bump you up from your baseline with that prehab first. And absolutely. The hard part right now with prehab is how it's fitting into the whole big picture. So some patients are candidates where they can wait 4 weeks before their surgeries, and some patients aren't. And so depending on how acuity and how fast your treatments are wanting to get started, prehab, that's where we're running into complications a little bit. But what I would say is as soon as you get that diagnosis, start to see if you can see a physical therapist then, so they can at least start you on a basic exercise program, get you to understand what may be entitled with your surgery and what things you can do in those early post-op days and weeks to start to rebuild your strength as you're healing. We call it like an active healing process versus a just passive healing. I definitely advocate, if anybody is in that position where they know they can, definitely try to get some prehab and get some understanding of what they're going into. I mentioned a little bit, one of the biggest things we do for patients who are about to start chemotherapy is, okay, if you're sitting there, you got to get moving. Get those hands moving, get those feet moving. And that is one of our more, if you want to call it a preventative measure to reduce neuropathy. Your body's still going to go through these treatments, and so we can't fully eliminate every symptom. But if we can reduce the severity of some of them, that's something we would definitely, I think everybody would benefit from and probably prefer. So yeah, definitely ask for that referral soon, or check out the APTA's websites to help get a therapist near you.
Great. Thank you so much, Alaina, for your time today and for a wonderful presentation. And have a wonderful day, everybody. Thank you so much.
Hello.
I think that's everybody.
All right.
That was great.
Thank you so much, Alaina. I ended up having technical issues as well on my end, so I'm glad. That must be something today.
I know. I was like, it's one of those days when you think everything is going to go smoothly, the day starts off beautiful, and then everything all of a sudden decides to crash at one time. You're like, okay.
Anyway, that was really great, super informative. And I know we get a lot of those biofeedback questions, so I'm glad that we now have a resource where we can turn to for some solid advice.
Yeah, and since I got myself so distracted, I was just trying to follow it. Do you know how many people were coming through that were, does it say what their kind of the different backgrounds of patients, or not patients, but people who are listening?
Yeah, so I don't have that immediately, but I can get that. We had over
just curious.
We had over 120 people register, and about 25 to 30 people were attending live. So what happens now is we send out a link to the recording and to those 120 people that register, and they'll watch it afterwards. And the link to watch it will live on our website, and I'll send that to you as well in case you want to share it.
We'll put on.
Yeah.
Very cool.
So, do you have any other questions for us?
I don't think so. I was going to mention too, if you ever want, I mentioned it briefly, one of our therapists that's came into our clinic is a speech and language therapist. And she has been doing like a big push on working with people in terms of chemo fog and cognitive fatigue. That if you ever want somebody like that in the future for either one of them, she's a pretty darn good speaker So it might
Yeah.
be a nice referral for you guys too.
Yeah, absolutely. I will be in touch with you in the new year. I think